Administering pain control is a huge responsibility. It's also one of the best things that we can do for a patient. And there are still 3 patients that get overlooked. I'll tell you who they are in this episode of One for the Road. The use of opioids for pain control has a storied and sometimes lackluster history in modern medicine, and we should always treat addictive substances like opioids with respect. We should use them cautiously, with proper consideration and monitoring. However, relieving pain and providing comfort are 2 of the most significant things that we can actually do for people in the pre-hospital setting. And there are 3 situations where we are still under-medicating our patients. The first one is isolated limb injuries prior to splinting. One of the problems with this particular scenario is that we often do pain control and splinting in tandem with each other instead of providing pain control prior to splinting. When the patient is hemodynamically stable, I would encourage you to begin with pain control and then wait for pain relief before splinting the limb. Too often in this scenario, pain control is an afterthought when it should be a first priority. Second patient is the abdominal pain patient. We still have a certain belief that if we medicated an abdominal pain patient pre-hospitally, then we could affect the physician's ability to properly assess the patient. And that is just untrue. Numerous pieces of research have indicated that proper pain control does not inhibit other clinicians' ability to properly assess and treat for abdominal pain. So let's drop that myth once and for all. You can medicate abdominal pain. It's okay to make those patients comfortable in the pre-hospital setting. And the third patient that we chronically under-medicate is the elderly. And we do this for a variety of reasons. Now, I want to point out that reducing our dosage in the elderly is entirely appropriate. As we age, our bodies process medications more slowly, and we should certainly be cautious with our dosing in our elderly patients. But they still require pain control. We sometimes neglect pain control in the elderly because of communication errors. They sometimes have difficulty in communicating their pain. They feel pain differently and more ambiguously. Hearing and cognitive issues can further complicate our assessment, and we end up with a patient population that we often just decide to let them tough it out. I want to encourage you to be patient with your geriatric patients, to take the time to explore their pain complaints, and to treat them cautiously but appropriately. So there it is. Isolated limb injuries, abdominal pain, and elderly patients. 3 situations where we should really consider if the patient could benefit from proper pain control. Thank you for watching. I hope you find that helpful. I'm Steve Whitehead, and that is One for the Road.